to Kids You See on Call, Urgent Issues in Pediatric Orthopedics live webcast from the International Pediatric Orthopedic Symposium, presented by the Pediatric Orthopedic Society of North America and the American Academy of Orthopedic Surgeons. The American Academy of Orthopedic Surgeons would like to thank GlaxoSmithKline for their unrestricted educational grant in support of this program.
Welcome you to our course and our webinar. It's called The Kids You See on Call, Pearls for Managing Urgent Pediatric Orthopedics. This is a course that is occurring live here at the International Pediatric Orthopedic Symposium in Orlando. We're in our fourth day of spectacular programming, and this particular course, along with one tomorrow on limb deformity, has been carved out and is being broadcast to leverage the incredible group of talent, faculty, thought leaders, et cetera, that we have here in Orlando this week. Our course is focused on managing problems that kids have who come in through the emergency room, and we've picked out a few different fracture types or scenarios, and we're going to give short lectures on those, and then we have two separate case presentation sessions. So in a moment, Peter Waters will come up and talk about montage and montage equivalents. He'll talk for 10 minutes. Then I'll follow with decision-making in pediatric femur fractures. Then we're going to stop and take a few questions based on those lectures, and I'll present some enhanced case presentations and use our faculty. Next, after that, David Skaggs is going to talk about supracondylars and pulses and hand color, followed by Marty Herman, who's going to talk about an infection update in 2014. And then Jim Beatty is going to do a second enhanced case presentation session. I think we're going to have a little change in the order here. Could we bring up the femur fracture presentation? And I'm going to start my lecture first, and that's going to be decision-making in pediatric femur fractures. So the purpose of this talk is really to explore all the different methods we have to treat pediatric femur fractures and all the different and the different kids they apply to, and try to help you a little bit with decision making. These are my disclosures. They're up to date on the website. So the first part will be the decision making, and then I'll provide some technical pearls for the various treatment methods. I got to start with a public service announcement. Every pediatric orthopedist, every orthopedist should know to consider abuse, child abuse, when a child who is not yet walking, and that's generally a child less than 1, presents with a femur fracture. Now we have 7 different treatment options. It gets a little bewildering for pediatric femur fractures. Everything from the non-operative, the Pavlik harness, walking spica, standard spica, to a variety of fixation methods, elastic nails, submuscular plating, external fixation, trochanteric entry nailing. And we have a series of factors that you as the surgeon need to consider for these fractures. The age. Younger kids heal fast and have astounding remodeling capacity. You really don't want to overtreat these young kids. Mobility. Are you really going to put a 10-year-old in a spica cast? Weight. Frankly, some kids are too big for elastic nailing. Fracture personality, and there the question is the kid at a high risk of shortening, and do you need to use a different treatment technique? And then surgeon, you as the surgeon, your skills, your experience, and equipment available. So you have this combination of treatments and factors, and how do you put it all together? Well, it actually fits together very nicely, just like the classification system used for whitewater rafting. So a class 1 rapid in whitewater rafting is just small waves, a few obstructions. They're easily dodged. You have no problems. You get to level 3, and you start to get some moderate rapids and tight passages, and it gets a little tricky. And by class 5, it's really almost life-threatening rapids that are only the biggest experts can do. And it's just like that in pediatric femur fractures. A class 1 pediatric femur fracture, it's going to heal itself. You just don't want to make things worse for the child or their caregivers. Class 2 is also usually non-operative, and we'll describe these, but you need to watch them closely. Class 3, we found over the years that operative is better than non-operative, and we're usually using a load-sharing implant. Class 4, you want rigid fixation, and class 5 is really the limit risk. You need operative treatment, and often stage treatment and associated injuries may take precedent. Let's see how that plays out. So the class 1 fracture, it's going to heal itself. You don't want to make things worse for the child or the caregiver. And some scenarios for this fracture are the infant that you just want to splint and use a Pavlik harness. maybe the child who's 4-year-olds and younger with a very low energy fracture, shortened less than 1 centimeter, you use a walking spica. And then the minimally displaced insufficiency fracture in children with chronic illness, cerebral palsy, other things, you just want a padded cast or a splint and not make things worse. The class 2 fracture is non-operative, but you got to watch these more closely because the stakes are a bit higher. So the scenario here is kids who are less than 4 with a low energy fracture with some shortening, maybe less than 2 centimeters. A walking spica is great, but you got to be ready to wedge. And then the kid less than 5, maybe with shortening up to 3 centimeters, a standard spica wedge. Class 3 is the fracture that probably has changed the most since I went into practice in the mid-90s. Here we're sure, based on evidence, that operative treatment is really better than non-operative. And we use load-sharing implant that's easy to insert and remove with minimal incisions and an excellent safety record, and that's often elastic nails. So these are the kids who are between 4 and 5 with a high-energy injury. They're shortened maybe 3 centimeters or so, and you could either use elastic nailing or traction and spica. And then kids who are 5 to maybe 10 or 12, depending on their weight. And this is a classic case for an elastic nail. In the class 4, this is a fracture that requires rigid fixation. You're just not going to do well with elastic nailing. So in kids 5 to 9, and again, fractures like this in that age group are pretty unusual, the high energy, comminuted, kid falling out of a building kind of injury, external fixation or maybe a submuscular plate. 9 to 12, but maybe high body mass index or length unstable, a locked trochanteric entry nail or submuscular plate. External fixation can be used rarely, and then 14 to skeletal maturity, usually a locked trochanteric entry nail. And then class 5, the issue here is limit risk. The operation may need to be staged, etc. For the younger kids with a mangled extremity or high energy open fracture, if you're going to do definitive fixation, you might put an X-fix on until it's healed, or a submuscular plate, trochanteric entry in an older kid. If you're going to stage them, you could use traction in a younger kid and then an X-fix and change out for definitive treatment. The difference for the older kid, the kid with the mangled extremity who's older than 12, you might, or with a neurovascular injury, if it's definitive, you're going to use a troch entry nail. If it's staged, you're going to use an X-fix and then change that out for a locked nail. Let's just finish with a few treatment pearls for these different methods. The Pavlik harness. This is perfect for that premature neonatal intensive care unit baby where they have IVs or lines in almost every extremity, and you don't want to put the kid in a spica cast for care purposes. Just put a little web roll around the femur, maybe a splint, and then put a Pavlik harness on. The fracture will be healed in a couple of weeks. If the child's going to go home, make sure the family knows to handle with care, because this is not a very pain-protective method. This method will work up to maybe 5 or 6 months. After that, a spica cast is better. Walking spica. This has become increasingly popular, especially in the U.S. This is just a long leg cylinder cast with a pelvic band. You want to flex the hip and knee about 45 degrees and reinforce the hip. It's very important to have a valgus mold at the fracture site. Almost all these fractures want to go into varus. And you want to see that kid in clinic at about 10 days after injury and be ready to wedge. Tell the families that the cast will need 10,000 Maltima. The standard spica cast. Don't put on the short leg cast and pull the femur fracture up to reduce it. We know there's a significant risk of leg compartment syndrome if you do that. In the standard spica cast, the hip and knee is flexed about 70 to 90 degrees. Put a valgus mold at the fracture site, and you got to see that kid in clinic at about 10 days post-op. Again, be ready to wedge. Elastic nails. Earlier this afternoon, we had a technique session on elastic nails here at IPOS. To highlight some of those techniques and critical issues, don't use elastic nails on the obese older kids. It's important to follow the French rules for symmetry of nail diameter and contour. You want maximum spread at the fracture site. Don't bend the tip away distally. Get your nail tips up into the dense metaphyseal bone. Expect the kids to be sore for 2 to 3 weeks. So we use a knee immobilizer for about 6 weeks. Some people like the end caps if they think the fracture might reduce a little on them. Submuscular plate. The plate should be long and strong. Don't use locking screws because they can cold weld and make it very hard to remove. Carefully contour the plate distally. Get the fracture out to length before beginning fixation and hold it with K-wires if necessary. And you want 6 cortices on either side of the fracture. External fixation. Generally when we're doing this, it's sort of damage control orthopedics. You can use it as a temporizing measure. Currently in my practice, I like external fixator as a portable traction. We'll put it on, get the fracture sticky, and then place a cast at 8 to 10 weeks to finish off healing. You want a long span with wide pin spread. Minimalist pin care is usually best. The key is no movement at the pin-skin interface. Sometimes I'll release the iliotibial band for knee range of motion. And then finally, trochanteric entry nail. You want the smallest diameter nail that's going to do the job. You want to enter far lateral on the trochanter, not at the tip. Minimal reaming of the entry site, and you want to lock it. Thank you. We are going to field some questions. They can come in by email as well. We're going to field some questions in a little while. But next, I'd like to have Peter Waters come up and talk to us about how he manages montasia and montasia equivalents as an acute injury.
Thank you, Jack. To me, this is actually relatively straightforward and a bit principle-based. So although it was a long time ago that Montasia talked about this, I think the principles are pretty clear. The first and foremost starts with recognition of the injury, and despite that, we continue to have significant problems with this. So publications more than 20 years ago and publications recently still indicate that up to 20% roughly of the time we fail to identify the lesion. So we get our eyes focused on broken bones, and we sometimes miss what's on the edge of our radiographs or our digital imaging these days. So be certain you follow the simple principle you learned in medical school early residency. Look above and below the fracture at each joint and be certain they're aligned. Lots of information about what is alignment in terms of the radiocapitellar joint, what is alignment in terms of the proximal radioulnar joint, including some recent stuff that David Skaggs' crew had looked at. John Hall used to say, this isn't horseshoes, being close doesn't count, but don't get stuck looking at the fracture alone, look at the joints. A number of classification systems have been written about that focus on the degree of displacement of where the head, degree and direction of displacement of the head, but it really comes down to ulnar fracture stability and length. So if you achieve length to the ulna, stability to the ulna, the radial head will generally follow. So acute montasia really is a proximal radioulnar joint dissociation with a forearm fracture. And the ulnar stability is absolutely the key to this. Jupiter's identified this with David Ring and talked about this quite a bit in the adults, and the same principles, I believe, are true in the forearm. So what choices do you have? You can do a closed reduction, and there was a time in which most of the pediatric textbooks said that closed reduction was the treatment of any pediatric montasia fracture dislocation. If you look at all of the series that have been written, you'll see by how we advocate that that turns out to be true roughly about 70% of the time. However, in your referral centers, you usually get sent the fractures that don't follow the simple rules. Other options are intermedullary fixation, and that's generally of the ulna. When you have an equivalent montasia, then it's radius and ulna both. Open reduction, internal fixation, and open reduction of the radial head with or without ulnar fixation. So the classic teaching, as I mentioned, really has to do with closed reduction, cast immobilization, but about 20% of these fractures will go on to loss reduction. This technique is best for plastic deformation and incomplete fractures, provided you recognize the lesion acutely. So you have to start with first recognizing the lesion. Intermedullary fixation has become commonplace for forearm fracture care. It stabilizes the ulna, it brings it out to length, and therefore generally stabilizes and reduces the radial head. We think it's best for transverse and short oblique fractures. The worry about using it in a long oblique, or more importantly, a comminuted fracture, is that that ulna can slide on your pin if it's not big enough or stable enough. Plate and screw fixation, long oblique and short oblique fractures, comminuted fractures. If you put a plate and screw on a short oblique or a transverse fracture, as a study that Jack's team and our team looked at together, it will work out just fine, but it may be more invasive surgery than you need to. In truth, the error with all this comes when you are less aggressive. There are some rare lesions in which the annual ligament or an osteochondral piece gets stuck inside the joint and you have to do an open reduction of the radial head. They are really rare. There's a nice paper out of Asia that look at annular ligament entrapment initially after reduction. You'll see the ligament in there, but somehow it gets out of the way. But you want to be certain that you identify this rare lesion as needed.